Today, we will briefly talk about different types of anxiety disorders, their demographic characteristics, clinical presentation, what's the DSM-5 criteria, medications. One thing that I want to lay out there is from DSM-4 to DSM-5, there has been shift. In DSM-5, panic disorder, agoraphobia, phobias in general, generalized anxiety disorder, separation anxiety disorder, and social anxiety disorder are clustered under anxiety disorder. Obsessive-compulsive disorder and post-traumatic stress disorder are no more under the heading of anxiety disorder. Obsessive-compulsive disorder also has gone under another cluster. On the other hand, fear is an emotional response to an immediate threat, and it is associated with our fight or flight reaction, which is more associated with autonomic nervous system. I tried to look for Pakistan-based data for anxiety disorders. So specific phobias are among the most common anxiety disorders. So that's my phobia towards dogs. And then C out of 100, and we see that, for example, feeling ashamed in separation anxiety disorder. It can happen in others too. Cognitive effects of anxiety can occur, such as it can cause confusion, distortion of perception. So C is roughly about 25%, which is a really significant number. Women are more commonly have anxiety disorders, and prevalence of anxiety disorders can decrease with socioeconomic status. So, social adversities can also play a role. Panic disorder can increase the risk of suicide. And panic disorder is generally is one that has later age of onset. So if a patient comes to you for panic disorder, always look for whether something else is there. 1/3 of patients who actually have panic disorder, they have major depressive disorder. And for any other anxiety disorders, depression is highly comorbid. So panic attack is sort of like a chest pain, right? So you need to see what constitutes panic attacks. So it's a sudden period of intense fear or apprehension that may last for a few minutes to an hour. And it generally lasts for 20 to 30 minutes. So if it is lasting for a whole day, then it needs to think about something else. So panic attacks, like I was mentioning, it can happen in other conditions too. It's not one panic attack that would constitute panic disorder. Recurrent panic attacks, which are unexpected, right? And there's an abrupt surge of intense fear that reaches to peak within a minute, during which time 4 symptoms are present. And just, get an idea of what that means. I'm not going to go through that mnemonic today. So some of the symptoms are palpitation, heart pounding, sweating, and a lot of it is around hands, trembling, sense of shortness of breath, feeling of choking, chest pain, nausea, abdominal discomfort, feeling dizzy, unsteady, lightheaded, or faint, chills or heat sensation, numbness, depersonalization. What briefly it tells you is that panic disorder is a diagnosis of exclusion. So you need to rule out other situations which can cause panic attacks or panic. Use it for short term, 4 to 6 weeks, and then try to taper patients off. CBT can be very effective for anxiety disorders. And always consider this if you have that availability in Pakistan. And it's mostly work on behavioral measures and cognitive restructuring. So it is usually fear of public transportation, being in open places, being in closed places, standing in line, or being outside of the home alone. You will see quite significantly in your patient population. And these are some of the normal worries that we have. So mnemonics for generalized anxiety disorders. So A was for actually anger or irritability. So just remember muscle tension, which can reflect in neck pain. A is for muscle tension. C is for concentration. H is for hyperarousal. E is for energy. R is for restlessness. S is for sleep. And only one item is required in children. Again, sometimes, people who are using drugs, it can can also cause some significant anxiety or worries. And it should not be explained by another disorder. I use GAD-7, and it is freely available. It's GAD-7. You can Google for that, and you can also download it on your clinic for free use. So as the name suggests, it's the cognitive piece, and then there is a behavioral piece. In behavioral piece, you work on, for example, deep muscle relaxation, progressive muscle relaxation and deep breathing and other techniques to help patient, feel a sense of control. And cognitive piece mostly work on checking those thoughts that are going on behind and what is the underlying thing that is driving that anxiety and restructuring those thoughts. You may not have time to do this in your clinic, so you may need to refer this patient out. And, sometimes there are a lot of YouTube videos too, so you can also ask patients to look out for YouTube videos or muscle relaxation. I don't know if it is available in Pakistan or not. So usually we try to start off with cognitive behavioral therapy in one of the SSRIs. One thing that we need to do when we are using psychotropic medications is you need to aim for therapeutic dose. You can also add CBT. If no response, then cognitive behavioral therapy or add a different antidepressants, but these slide sets would be available to you. For medications, benzodiazepine are not the first line of the treatment. Use low-dose long-acting benzodiazepine. So I will recommend using maybe something like clonazepam if you need to use it, and use it for very short term, for 4 to 6 weeks, and then try to taper patient off. Otherwise, they're gonna go into habit of using it more and more, and then you need to increase the dose. Neuroleptic medications are antipsychotics. They are not first-line medications. Again, using these one, I have not typically used this, but my goal is always to go back to one medication. With anxiety disorders, start with lower doses of medications. Like if you're starting sertraline, start with 25 milligram. And if patient is tolerating it, okay, go to 50 milligram, but then increase the dose. Don't sit on those doses for too long. Paroxetine is category D for pregnancy. Others are category C. For children, fluoxetine and then sertraline. But I think that is very individual response. You can start with Lexapro escitalopram. The reason being that fluoxetine has significant drug-drug interactions. So if patient has QTc prolongation, you need to be aware of that. Black box warning with suicide. How are we doing with time? And then there were significant studies done after that. I hope all of you know what meta-analysis means. So 4 out of 100. 2 out of 100 who were on placebo had increase in suicidal ideation. So yes, antidepressants can cause increase in suicidal ideations, but the risk is only 2%. And I saw some studies where there was a decline up to 30% in SSRI prescription. And in those studies, the frequency of suicidal ideation went up to 20 to 25%. So if you treat with medication, your risk is almost about 4% with medication and 2% with placebo. Are usually prescribed once a day. For some reason, I've been seeing these prescriptions from Pakistan, and it's usually prescribed twice a day. Escitalopram, escitalopram, and paroxetine twice a day, once a day medication. Unless you see, I have not seen any patients in my patient population that would need twice a day. But I don't think there is a reason to dose it twice a day. Fluox, some of the side effects that can happen. So you need to educate your patients that it will go away if they keep taking their medications. So they are aware of it. And once, if it still lasts, if it's causing significant impairment, then, you need to see what can you do. If you don't ask, they're not going to tell you. Then drowsiness and sleepiness can happen if you dose at night. That does help. Weight gain can happen somewhat with some antidepressant, not a major concern. Then headaches, dry mouth can happen, especially with medications that have anticholinergic effect, one of them being citalopram. Constipation, stomach upset. They can also cause movement disorder in a very small number of patients. If patient, have history of significant bleeding, you need to watch for that, what is causing what. Diarrhea with sertraline can happen. It is, in my opinion, it is a, side effects wise, it's well tolerated, but you need to go to higher doses to see the benefit. Mipramine has indications for panic disorders and treatment-resistant GAD. Doxepin can be used for anxiety and insomnia. H1 blocker, 20 to 50 milligram can be used as needed for anxiety.